We're now live, Chair.
Thank you very much. Good afternoon, everybody, and a very warm welcome to the September public board meeting of Wye Valley Trust. I'm Frances Martin, Vice Chair, and I have the privilege of chairing this afternoon's meeting. We are live streamed, and this is available for people to watch later as part of our commitment to being open and accountable to the public in all that we do. As is usual, our board papers will have been published on our website, and so hopefully people have those to follow, and we will broadly follow the agenda, but we will do a couple of things out of order to allow us to welcome some special invited colleagues this afternoon as part of our Going the Extra Mile Awards. So we'll get onto that shortly, but first of all, I'd like to note apologies for absence. I have Russell Hardy, our Group Chairman, Glenn Burley, Group Chief Executive, and Eleanor Bulmer, one of our non-executive directors. I don't think we have any other apologies for absence this afternoon. I'd also like, apologies, Lucy.
Justine Jeffrey, Director of Midwifery, apologies for today, Chair.
Thank you, Lucy. I'd also like to welcome, in addition to Stephen Coleman, our Chief Executive, we're keen to welcome Sarah Shingler, who, following the retirement of Jane Ives, that we'll hear more about later in the meeting, will be joining us in October as our new Managing Director. So Sarah is joining us in an observational capacity this afternoon. Has anybody got any declarations, either new in general or particular for this meeting, that they would like to declare? No, I will take an absence of digital hands as no new declarations. So therefore we move to one of the nicest bits of our board activity, which is to be able to say some thank yous. And colleagues who have joined before will know that we have a scheme called Going the Extra Mile, and it is a tiny snapshot because every single day of the year our colleagues go above and beyond to deliver the care that we would want for our families and friends. But every quarter we pick out a few people for particular mention, and so we will start with the winners for quarter one for the team of the quarter, and have a citation to read to you this afternoon. The team of the quarter is the Specialist Palliative Care team. And the team is an integrated team working across the acute hospital and in the community, supporting patients and families with complex needs at a very distressing time in their lives. They step into challenging situations every day where other health professionals may stand back. In the current health climate, where there's immense pressure on services, they all go above and beyond their roles to ensure patients and families get an extremely high standard of care and are frequently innovative about the ways that we can give person-centred, holistic care. And we're delighted to have two of our colleagues with us here this afternoon. And so very well done. Many congratulations. Keep up the good work, and thank you for all that you do. Thank you. You're very welcome to, I don't know if there's anything you want to say, you absolutely don't need to, and you're very welcome to stay with us for the meeting, but I appreciate that I'm sure you've got other more pressing clinical matters that you want to get on with, so we'll quite understand if you go, but please pass on our thanks and congratulations to the whole team. Thank you. The second award is for our employee of the quarter, and that's Kelsey Beddoes, who's a member of the education team. Kelsey has recently joined the team, and previously we've had issues with students, but I'm always asking her questions and contacting her for different things. She's so efficient and supportive. Her communication is amazing and very timely. She's been a real asset to us as a team, and especially to me while I'm still developing my role. Kelsey consistently demonstrates each of the trust values in endless amounts, a role model for our team, colleagues across the trust, and students alike. So many congratulations to Kelsey, who unfortunately can't be with us here today, I don't think, but well done and thank you very much indeed. Keep up the good work. Thank you. Right, we will now move on to the minutes of the meeting held on the 3rd of July. Has anybody got any matters of accuracy or omission that they would like to note? No. Good, thank you very much. So the matters arising, there were just two from that meeting. The first was an update on the PFI performance issues, and I'm pleased to note that we have an update coming to our October meeting from our Sodexo and Mercia partners. So that is on the agenda for our next meeting. The second one was one for our Chief Financial Officer, Katie Osmond, to share with board colleagues details, more detailed operational plan and budgetary analysis, which has been shared, and therefore I propose that that is closed, and we'll obviously be picking up with our budgetary and financial planning as we go through the year, but thank you for that, Katie. Okay, so the first substantive item is the Managing Director's report, and so I will hand over, Jane, to you, please.
Thank you very much, Frances. So mainly this is sort of more of a strategic overview of things that are going on, and there's a huge amount that's going on. I sort of feel like the 1st of September, when we started this week, almost is the beginning of implementation of the 10-year plan that was published back in July. The publication of the operating guidelines for planning for next year really fires the starting gun. The oversight and framework, which has been published, and will put every trust into one of 4 segments, with 1 being the best and 4 being the worst, and also a segment 5 for those that are going to be under national intervention. It hasn't been published what segment we're going to be in yet, but we are pretty reliably informed we're going to be in segment 3. And there's 2 reasons for that. One is around performance, and we don't know where we're going to be on performance yet because it depends on benchmarks with others, and we haven't got the detail. But we could be in segment 2 for performance. But because we've got an underlying deficit and we're in receipt of financial support, that means we are pegged back to segment 3. Even if our performance was at level 1, we would still be pegged back to segment 3. And the reason I sort of mention that is that I think it's really important for us to recognise where we are from a performance point of view, because personally I would say that it's about whether we're meeting our financial plan or not, rather than we've got historical deficit support. That seems to me to be more important. And so I do hope there is some change in thinking nationally as we get into next year around being on your financial plan is what derives what segment you're in, because the segmentation and the access to becoming a new foundation trust is related to that, and we wouldn't want to be sat in segment 3 for the next 5 years, which, as we went through our workshop this morning, we think it's going to take 5 years for us to get back into financial balance again. So I mentioned those things by way of context. As I say, the guidelines are out for us to start our planning, and it really is going back to, I'd say, old-fashioned proper planning. So over the next few months, the commissioners need to put in place a 5-year strategic commissioning plan. We need to put in a 5-year integrated delivery plan, which also includes that route back to break even financially. And so it's more than what we've been doing really since COVID, which has very much been sort of quite hand to mouth, 1 year at a time, doing planning over that time frame, a proper strategic plan. So a lot of work to do over the next 3 months to pull that together. But we've already started doing our financial planning, and as I say, we talked about that in our workshop this morning. And in terms of our service planning, we've already got in place the meetings with our services to go through the plans for each service over the next couple of months. So we will be in a place to be able to deliver that plan. And then the thing that's new, which we haven't had before, is also a neighbourhood health plan. So a huge part of the 10-year plan is around how do we move from acute to community and from treatment to prevention. And really that's around how our neighbourhoods work differently. So how our GPs, our community services, the voluntary sector all work differently in the community. And so the expectation is there will also be a neighbourhood health plan that needs to be signed off at the same time. That's going to be under the leadership of the Health and Wellbeing Board, as I say, because it's very much how partners work together. So I think that's some really exciting work. And again, from the work we've done previously under One Herefordshire, we will be in a good place to pull that together. I probably wanted to mention just the ICB changes. So we are now aware that our local leadership team of our local ICB has been appointed to the leaders as chair and chief executive of the cluster arrangement for ICBs. And so firstly, congratulations to those individuals, and also it's great that there'll be continuity for us working with the same people who we've worked with really well with over the last 3 years or so. I wanted to talk about I touched on this at our last meeting, but I want to talk again about the Powys commissioning changes. We have now put in the plans to extend those people who are on routine waiting lists, to extend the waiting times for those people, and we're sorry we're having to do that, but that's what the Welsh Powys Health Board commissioners have instructed us to do. And for those patients, we've already seen those patients and we know how they are. And so we have a view on whether that's clinically safe to do that or not, and we can bring them forward if we think that it isn't. However, the next part of that, which is to extend the waiting time for patients referred for a routine outpatient appointment to a year, is something that we are back in discussion with the Powys commissioners about, because we won't have seen those patients and we won't see them for a year under this plan. And so if our waiting list is shorter, we would want to see them at the time that our waiting list is there. And it's important that for their GP, they're the people who've had eyes on the patient and they know what the level of risk is. So obviously they can refer that patient as an urgent patient and we'll see them more quickly. But it's probably better that the GP holds on to the patient and then refers them at the time when they know our waiting list will come in line with the commissioning requirements. So we're having some discussions with the health board around that, and there's been a letter that's gone from our chief medical officers about how concerned we are about the safety of the way that it's proposed at the moment. So no doubt we'll be continuing to talk about that, and we'll come back to the board to talk about that as well. And then lastly, I just wanted to say I've been on an NHS board for 25 years, but this is the start of something of a long goodbye, really, because almost every meeting I do for the next 3 weeks is going to be the last time I do something. And so we have got our annual general meeting in 3 weeks' time, and so I'll probably say a little bit more then. But I did want to just take a moment to thank the team that I work with, who are individually impressive, I think collectively absolutely excellent, and have been such a privilege to work with you all. So just wanted to say thank you, but I'll have lots more opportunities to say thank you to people over the next 3 weeks.
Thank you, Jane, and I'll also be saying some things about you at the end of the meeting, so you don't escape. But I agree, there are more opportunities to say goodbye and to say thank you. Colleagues, any questions or comments for Jane on her view of the world today? No, many of the issues will be picking up. Sorry, Stephen.
No, I just think in a future board, I think as Jen rightly describes, I think the architecture of what we'll be working with over the next few years really is really starting to come together in terms of the performance framework, the new kind of planning rounds that will be in, the time frames that would be. So I think we'll do a lot through board development, but I think if probably in a couple of months it might be worth us doing something at the board, just kind of describing that, so people watching, the public, our colleagues will kind of will be able to describe how we're knitting it all together and what that means for us, because there's been a lot of moving parts, but it does kind of feel like we're starting to move that together.
Yeah, absolutely agree. If we could put that on the forward plan, and I agree, it does feel very different. Colleagues who've worked and been around the NHS for a long time know that it used to be a Christmas present to have the planning framework. In recent years, it's been sometime in the new year. So getting ahead of the game and being more proactive is certainly something that we welcome from a provider and a collaboration perspective. Okay, so let's move on then to the integrated performance report. And what would you like to say by introduction, Jane?
Yeah, just a few things. So I'm going to start off with some of our quality metrics, and I'm really delighted that we've rolled out that feedback from patients even further. It's really important we get that feedback from patients and increasingly use it in the way that we plan and deliver services. But it is also part of that fundamental change under the 10-year plan, that that different relationship and engagement with patients, but also with communities and sort of citizens, and that's one small part of what we need to change. But it's good to see that developing. I want to just mention, and I know Chizé will say more about it, and we talked about it at Quality Committee, but it's really good to see the work that's been done on our mortality monitoring, because we appear to be worsening, but that change to same-day emergency care recording, which we were one of only 40 trusts that did what we were asked to do and changed the recording back in July of 24. And because the benchmark has now really changed, so the work that's been done, I think, gives us a lot of assurance that actually we are broadly still in a good place. And if we'd have carried on monitoring in the same way as most of the NHS did, that's what our results would be showing. I want to talk a little bit about urgent care. Anne's going to talk more about it, because we have been moved into Tier 1 because of our urgent care performance in Q1. Now, we saw some very significant improvements in July and August. I have to say the last 10 days or so have been very difficult, and so there's a lot more work that's going on. But Andy will talk more about that. But it's absolutely at the heart of improving quality and improving finances, making sure that we manage our urgent care pathways really well, not just in the hospital, but much more broadly than that across with our partners, and particularly with primary care. So a concern that I do have is around our number of patients waiting over 52 weeks has been going up over the first half of the year. There are plans to bring it back down again, but just to highlight that we aren't where we expected to be at this time of year, and there's a lot of work to do to meet the target of only 1% of our waiting list waiting over a year by the end of by March the 31st. So it is an area I'm concerned about. Andy might want to say a little bit more about that. I'm very confident our teams are clear about the task. They've got plans to deliver, but there are some risks in that. Along with the people metrics being generally positive, I think our recent flurry of recruitments of excellent candidates into our consultant workforce has been really impressive, particularly in our emergency department, where the department we've struggled with for quite some time. With I think at one point we were two substantive consultants during my time here, but we're moving up to 8 with our new recruits and really excellent calibre. But it's across a whole number of specialties where we've done really well, and I think that is a reflection of us becoming a more attractive place to come and work because of the improvements that we've made. And then very lastly, again, Katie will say more detail about it, but to draw the contrast to where we were this time last year in terms of our financial plan, where we were well off trajectory. we are in a much better place this year, and so it's really good news to be a little bit ahead of trajectory at this time of the year, but we've got an awful lot more to do. So those were just my opening remarks.
Lovely, thanks Jane very much, and yeah, echoing many of the congratulations and well done, and some positivity, but a recognition of the significant pressure that and the experience that therefore that some patients are having who present through our emergency department, and some of the long waits that are very much not what we're wanting to see. As you say, autumn has arrived with a flourish and some of that capacity pressure. So we do encourage people to choose wisely and make the most of 111, using community pharmacy and other avenues through general practice, and really considering whether the emergency department is the best location for them to arrive, which will help us to make sure that we see and treat people as quickly as possible. Any other questions for Jane, or should we move into the body of the report? Okay, let's proceed. So we will start, as Jane did, with quality. So Lucy Chizu, over to you.
Thank you. I'll start and then hand over to Chizu, if that's okay. So just a few things from me today. Firstly, just to say that the cancer survey from the experience of service users during 2024 was published in July this year. And the detail of that was presented at Quality Committee last week. 500 patients responded to the survey, which gave us a 60% response rate, which is really positive. A couple of areas of focus for us that we're looking into in more detail at the moment is the experience of male patients with cancer, and we know that that's an issue nationally, so we're just digging underneath that to understand the details so that we can focus on where we need to improve. And secondly, around the experience of our Welsh patients who experience care partly in Wales and partly within our services. So just to understand that in more detail, so that we can improve cancer care in those areas. At Quality Committee, we asked for a little bit more information around particular cancer pathways, and the team are going to bring that back in the next quarter. But overall, the cancer survey, a really good set of results for us. You'll note in the cover report that we had a UCAS PAM pathology accreditation visit, or visits, should I say, throughout June and July, which was a review of all of our pathology services. And following the end of that accreditation visit, the visiting team highlighted that we had over 80 areas requiring improvement and that required a mandatory response from us back to UCAS. I'm pleased to report that the majority of those were straightforward, and we were either able to rectify immediately during the visit or shortly afterwards. But there were particular concerns around our quality management oversight, particularly in relation to audit and risk assessments, and the time that the quality manager had to oversee that. I'm pleased to report that team have responded swiftly to UCAS. Our quality manager post to add more capacity into that is currently out to advert, with interviews planned for the 12th of September. We have responded to UCAS within their prescribed timescales and submitted our evidence around those 80 findings. Pleased to note that 54 of them have already been reviewed by UCAS, accepted as satisfactory and closed down on their systems, and the remainder are undergoing review currently. A further visit will take place from UCAS in December, and where their particular focus will be around our audit programme and the progress that we've made since their accreditation visit. And we'll feed back to board in due course in relation to those matters. But just briefly touch on cleanliness. Since we last met, we had an inspection and the outcome of that inspection from NHS England and ICB colleagues. And we moved from intensive monitoring to enhanced monitoring. So that was really positive in terms of that inspection. And the team are coming back to visit us on the 18th of September. And their early view was that providing we continued to demonstrate the progress that we were able to do in June, then we should move on to routine monitoring, which would be a really great place to be. And I've been holding executive-led meetings with Sodexo colleagues, estate colleagues and clinical colleagues to make sure that we're on track with addressing those matters that were identified during the inspection. And then finally, you'll see in the report, I include a little bit of detail around patient engagement. Jane already alluded to that rollout of the family and friends test to all of our services, but we've also changed different methods and different ways of individuals being able to feed back to us about their experiences, which is really, really positive. We have added into that a more detailed survey that patients are able to access. And we know that that will provide us with much more qualitative detail to enable us to focus on true service improvement where we need to. And although it's not included in the report, I did just want to touch briefly. So podiatric surgery was an area that didn't have family and friends test previously. During the month of July, we sent 70 texts. We had 70 responses, so 100% response rate. And 100% of those responses gave the service 5 stars. So we now know that podiatric surgery have set the bar and set the standard for all of our other services moving forward, and we're really proud of them. And I just include, finally from me in there, a little bit of information about our new interpreting service that we moved to in April of this year. Largely, it's gone down well. A couple of teething issues, as you would expect, and we're working through those. But actually, overall, the service has been received positively. You can see in my summary that we've used 35 different languages so far since the service went live. But the main benefit for our patients and for our clinicians is that all of those interpreters are experienced in healthcare, which makes that conversation and clinical interactions much more positive for patients and clinicians using the service. I'll hand over now to Chizo for the mortality, and I'm happy to take any questions at the end. Thank you.
Yes, thank you. So our 12-month mortality indices, which is the shimmy that looks at observed versus expected, continues to rise. However, the assurance we have is, as Jane said, accrued mortality rate. The total number of deaths we've had has remained one of the lowest we've had for years. And we do understand why we have this disparity. It's because we have removed SDEC from our denominator, and we're one of only 40 trusts in the country that have removed SDEC from our denominator. So we are continuing to focus on quality in trying to improve our big diagnostics. So a fracture neck of femur, the work we have been doing in test of change has led to more of our patients being admitted onto the ward and receiving definitive treatment within the target time. We're continuing to audit our sepsis and seeing increasing, reducing numbers of mortalities there, and we have a process map mapped on the 18th of September. We're also focusing on coding to ensure that we code all our spells, and also to look at things like the number of patients who have a CCI score of 0 to ensure that we maximize the coding. Thank you.
Thank you very much, Chizu and Lucy. Any questions or comments from colleagues for either Chizu or Lucy? No, a couple of quick thoughts from me. Reassuring, it's frustrating if not all colleagues are counting the data in the same way, but reassuring in terms of our mortality. But we will continue to track that to make sure that we don't have false assurance, and hopefully colleagues from across the country will adopt the revised counting methodology shortly. Very good news about the breadth and depth of friends and family tests and the reporting, and I echo your comments, Lucy. 100% obviously is now the benchmark, so we welcome. And for members of the public, users of our service, we very genuinely want to know how it feels for you. we are here to provide the care that we want for our families and friends, and therefore we need your help in assessing how well we're doing against that, and we want to be able to listen. So do, if you can, please take the time to respond to the messages and give us any help that we can in terms of things that could be better for you, or things that you think have been really good that we want to make sure we provide for all patients and service users. So thank you for that. Another bit, just picking up because it's topical today, I believe that today would have been the 18th birthday for Martha Mills, and her parents launched the campaign to improve the use of critical care outreach and the ability for patients and families to ask for enhanced scrutiny or a different assessment of the care that people are providing. And we have adopted that in Wye Valley Trust, and we would therefore always want patients and their relatives, carers, to be able to alert us if they think that there are changes in a patient's condition that we may not have already spotted that could be important for their future health and well-being. So we're very much in line and supportive of that national initiative. Okay, let's move on. Thank you, both of you, for that. We've already, Jane has trailed various of the discussions that we had this morning in our workshop, and one of those was about some of our cancer performance and the pressure that we have on non-electives. So Andy, what would you like to pick out of the your activity report for us?
Yeah, I'm just going to elaborate a bit more on sort of tier one. You know, disappointing that we're in tier one, but obviously we've got to acknowledge some of the challenges and some of the dips in our performance standards and quality of care that we were delivering in Q1. And I've reported to the board before how we had a number of workshops in the early part of the summer, and within my report, which mainly reflects on July, how we managed to turn around a lot of those performance targets and get back on trajectory, and make some real improvements across the summer. And that, if I just highlight into August, although it's not covered in my report, continued into August until we got to the last week in August, where it became extremely challenging. However, saying that, our August trajectory was significant, our August performance was significantly better than Q1. We're only 3% behind in our 4-hour trajectory, and our 12-hour trajectory remains on plan. And our ambulance handovers, although challenged particularly in the last week in August, was much better than Q1, and again just behind our trajectory in terms of making sure our ambulance colleagues can hand over 45 minutes. As Jane already mentioned, we have had extremely challenging in the last 12 days, and that's been mirrored across the region. However, we are seeing some sustainability in some of our performance, even across this challenge period, that are still significantly better than where we were in Q1. So that is positive, and it's good to see some of those sustainable changes are continuing despite some of the challenges, particularly in our non-admitted performance in ED, which still remains strong. So what are we doing next? Phase 2 workshops start this month. Again, 2 workshops with a multitude of clinical and operational teams focus on some key particular areas. One is our SDEC, our same-day emergency optimization, changing the mindset of our teams around SDEC as default rather than ED as a default, capitalising on our streaming, getting our criteria and processes right, and ensuring that when we've undertaken a capital build that's happening over the winter and hopefully due to go live in February, that everything's in place, that when we triple the size of our SDEC and ambulatory offering on the acute floor, we've got all our ducks in a line and our processes right and are streaming patients to the right pathways. This includes direct admissions from our urgent community response team and ring fence and ambulance capacity in our SDEC areas. NHS England have already are going to provide some support in acting and providing some critical friends to review some of those plans, included in our workshops and also ongoing into the rest of this year, just to make sure that our plans have been sense checked by peers. The other area we want to focus on is our ward-based processes. Lots of digital transformation going on ahead of the winter, particularly on our bed management system and the use of AI in our ward rounds to release clinical time and increase our productivity, as well as looking at ongoing ward-based processes, particularly around pathway 1 and pathway 0, and having that home first mentality, and particularly around focused discharge reviews on key wards with our integrated discharge team combined with adult social care across Herefordshire and Powys. We're also looking at our internal professional standards focused on early discharge and flow, and our ESIST support that's provided through that tier 1 offering is going to be helping look at how our ward-based processes, looking at our internal professional standards, helping us build that early flow and discharge processes with peer support from across the region as well. Just moving on from urgent care, just looking at RTT, it is pleasing that our RTT performance is improving in terms of the 18-week standard. But as Jane has already mentioned, our 52-week challenges remain, particularly in 4 key areas, predominantly gynecology, ophthalmology, T&O and ENT, with the latter 2 having the biggest challenge currently. The surgical division have developed some really robust plans to get our 52-week position back on track and on trajectory through Q3, and they'll be reported through weekly and monthly assurance meetings and summarised at our finance and performance executive meetings on a monthly basis. And then finally, just on diagnostics, overall, we've seen really positive reductions in the overall waiting lists, particularly in terms of echocardiograms, which has reduced their number of patients over 6 weeks from 900, which I last reported in my last board report, to 650 currently. So a real improvement over the last 4 to 5 weeks. It's under control, and we're hoping that we can get to at least 400 over 6 weeks by the end of October, heading towards 200 by the end of this quarter. Our focus now is on endoscopy, where there are a number of patients waiting over 6 weeks that we need to focus on, but with plans there, particularly around positive recruitment and increased capacity in Ross on Y Community Hospital for endoscopy across 5 days in October. Hopefully we can get on top of those endoscopy backlogs for our patients. And that's my summary. Thank you, Chair.
Thank you, Andy, very much. A lot going on, as you say. Any questions or comments on the activity section for Andy? No, keep up the good work. Glad to see the focus on some of the long waiters and everything we can do to prioritise those, but some very positive final message around diagnostics. So, and obviously with our community diagnostic centre opening, there's an awful lot going on that will increase capacity within the county very shortly. So thank you very much. Another issue that we talked about this morning was our board commitment to equality, diversion and inclusion, and obviously that's part of Jeffrey's remit as our Chief People Officer. So Jeffrey, what from your report would you like to pick out for the board this afternoon?
Thanks, Francis. Following formal consultation with our trade union reps, we've now started the consultation program for our admin and clerical staff. So the organizational-wide change program has now commenced and will run over the next 4 to 5 weeks. So we just want to assure all staff involved in this that we will handle this in a compassionate, fair and objective manner, working actively with our trade union reps. So trade union reps are working with us in close partnership, and the HR team are supporting line managers over the next few weeks. So just to provide that reassurance that things will be held in a very compassionate manner. We're starting to see a reduction in sickness absence following the introduction of the revised sickness absence policy, and the whole reviews and drive to reduce sickness absence remains a key focus area for the HR teams. Over the coming months, we'll make sure that we maintain the momentum. And I mentioned previously that Wye Valley will be part of a national study looking at sickness absence. So that study has now commenced and will run over the next few months. And Wye Valley will feature as a case study organization within that NHS-wide national study. The report on that will be presented sometime next year. We continue to promote EDI activities across the trust because it's a key priority for the organization. So we continue to support a variety of EDI activities. Our annual Health and Wellbeing Week will run from the 6th of October for a week, and we will use that time throughout October to really encourage employees to take the flu jab. So we're going to be actively encouraging all our employees to get vaccinated, because we know that's one key way for us to try and address sickness absence, certainly over the winter months. So we'll be pushing that through from October and beyond. And finally, we are on track with our workforce plan. So we monitor our workforce movements on a monthly basis using the workforce tracking tool, and to date, we are heading in the right direction. So we'll continue monitoring that over the coming months. So we're very determined to maintain our workforce plan, certainly for the rest of the financial year. Those are the key things I wanted to pull out, Francis. Happy to take any questions.
Thank you, Jeffrey. Any questions or comments for Jeffrey? Some really positive movement on those metrics, as you said. I just wanted to pick up on the flu vaccination. I will certainly be having my flu jab, encourage all board colleagues to do likewise. And I am very pleased to see the change this year to go back to peer vaccinators that we had during the pandemic, to make it as easy as possible for teams working clinically over a 24/7 work plan to be vaccinated. So encourage people to do all that they can to protect themselves, their families, and all of our patients. And I'm sure there will be a small competition between teams to see who can get to the highest vaccination rate between their team, and I look forward to presenting the prizes in due course. Okay, thank you. Let's move on then to our financial performance. Katie.
Thank you, Francis. So I'll cover 3 areas as part of the report today. So our progress year to date at month 4, a forward look in terms of year end and risk, and then a piece around cash and capital in the usual way. So in terms of where we are over the first 4 months of the year, we've had a really stable start. As Jane's report alluded to, we're £327,000 better than we'd planned to be at this point in the year. There are a number of drivers within that year to date position. So we've seen really strong progress on our agency reduction plans. We're 400k better than we planned to be at this point in the year on agency spend, and in the month of July our agency spend was 3.2% of our pay bill, which is the lowest it's been for some years. In the month, we've had a benefit of a one-off rebate linked to our maternity insurance clinical negligence premium, which has clearly positively impacted the position. But on the first, we also had some cost for industrial action. So if you take all of those things out, overall, we're in a really stable place at this point. Elective activity, as Andy's described, is broadly on plan for where we would have expected to be. Income overall is behind plan, but that's because of some known timing issues and some areas where we'd planned income and expenditure to match, and they've not yet materialised on either side. So there's an equal and opposite. In terms of our efficiency delivery year to date, we're about £900,000 better than where we'd planned to be at this point in the year. And in terms of the plan, we've said before, it's phased largely to start to increase across the year. So in the first 4 months of the year, we've got 20% of the target. So 20% of the target in a third of the year. So that in itself explains the rise in the latter part. So although it's a really pleasing position to be in at this point, the challenge does remain significant moving forward. And we are really focusing on mitigating risks to delivery of those schemes to maximise the achievement of that target across the year. Outside of looking forward then, so outside of the increased land level of CPIP, which is a significant risk, we've also got risk, as Jane alluded to, around our Welsh funding and some of their commissioning decisions, and a range of smaller risks as well. In terms of mitigating and managing those risks, so we're tracking run rates and financial forecasts at a divisional level through the finance and performance executives, and at a trust-wide level through our financial recovery board, where we go into more detail as a board around some of our financial position aspects. And that really is about enabling that early sight of risk so that we've got time to develop mitigations rather than running out of the year and not having capacity to do so. In terms of cash and capital then, so cash balances were 5 million higher than we planned for the end of July, and we continue to really proactively manage our cash on the basis that we know it becomes challenging as the year progresses. In terms of access to the deficit support, which I know I've flagged in previous meetings, as a system, we've secured access to that planned support for Q1 and Q2. Thereafter, access to it remains contingent on our financial performance and delivery of those efficiency targets. So collectively, they remain really important. In terms of capital, we're spending ahead of the plan year to date, but we're confident that's just around timing issues of schemes progressing faster than we'd originally envisaged. And although resources overall remain constrained, we are confident that the overall forecast for the year remains on plan, so there's no material concerns. Finally, the report references the start of medium-term planning, and Jane's touched on that in her update. And as we've said, we had a really useful session at workshop this morning, so more to come on that in future board meetings. But happy to take any questions.
Thank you, Katie. Very helpful and comprehensive. Any questions or comments for Katie on the finance report? No. One thing from me, just about patients from Powys, and for people who may be anxious about it, we are the local hospital provider for 40,000 or so people who live in Powys. So these are not out of area patients. They are our area, but because they reside and registered with GPs in Wales, it is commissioned through a different route. So we care very much about providing the care. I think what Jane and Katie have just described is some of the bureaucracy that goes around that, but our commitment to providing the best and most responsive care that we can to patients from Wales is unwavering. There is just some logistical things that we need to overcome, but we continue to take seriously our responsibilities to people who live across the border but need our care at times. And yeah, picking up about the medium-term financial planning, as a reminder, over the pandemic years, some of the funding for NHS organisations went out of some of the usual plans and means. What we need to do as part of our responsibilities with the 10-year plan is to get back into a system of balance, and that's what we're working to do, is to how quickly we can do that. And that's about providing the right care in the right place at the right time. And we know that sometimes there are steps in the journey that are unhelpful for some of our patients, and we heard about a very important innovation this morning from one of our clinical teams to speed up the journey from acute presentation to needing surgery, which used to take some time and cause patients pain and distress in the meantime. So we are absolutely looking at all opportunities to provide early intervention, timely care, and stop conditions getting worse over time, with all of the distress that that causes to patients, but also the consequent use of NHS resources that we could use more wisely. So those are all part of the ways that we are committed to living within our means and balancing the books at the end of the year. So grateful for your leadership with that, Katie. Okay, so we'll move now to the section which is items for approval. We have a very comprehensive set of papers around the winter plan, and colleagues are aware that not all of it was included in the pack. Some of them are too large, but they have been made available for board members to review. I don't plan to go through all of that detail, but Andy, what would you like to pick out to ensure that the board are fully sighted as you're asking us to endorse the plan for submission?
Thank you, Chair. Yeah, hopefully board members have had time to read the presentation, which is a really high level summary of lots of work in various local plans in order to get ourselves in the best possible place for winter. I think it's fair to say that although this is badged as a winter plan, in terms of my previous update, in terms of what we've been trying to do regarding urgent and emergency care and our improvements there, they're one in the same. There isn't a different plan for winter. Our plan is our urgent and emergency care plan, and those schemes in some high level detail are covered within the PowerPoint that is shared with the board, and particular areas to focus on are included. In terms of just some highlights in the winter plan, just to draw the board's attention to, as part of the plan we were asked to model the impact of our schemes and their delivery on our 78% or our ability to meet our 78% achievement of the emergency access standard and bed capacity. And the request in the national ask was to model our baseline surge and super surge scenarios. Our bed modelling has been based on surge because unfortunately for Wye Valley currently we always run hot and are always running at some degree of surge because of the temporary escalation spaces and boarding patients that, although we eradicated for some time during the summer and was a better position than we have been for some years, we still continue unfortunately to use those. The plans cover a full list of the UEC schemes, including how we're going to improve discharge to assess, admission avoidance, and particularly including that PCN, management of frailty admissions, and respiratory mobile MDT teams, focusing on 600 high-risk respiratory patients over the winter to ensure that those patients aren't admitted or readmitted. It also includes discharge targets by day and by pathway, which we utilised in conjunction with our emergency admissions predictor on a weekly basis. And Chair, as you already mentioned, our community diagnostic centre comes online this month, and the impact and improvement on our urgent and emergency care delivery is included within that plan, whilst we look at further pathways to work with our urgent community response teams and how we can move some of that work away from our same-day emergency care settings to our CDC settings, and also focusing on our breathlessness pathways as well. The plan also includes PALIS and summaries there about their plans for winter, and we continue to engage and regularly review those plans with their operational and clinical teams through attending local events. We're also included in the plan is our escalation processes. We've reviewed our escalation plans across our escalation policies and our escalation matrix ahead of the winter, and our plans also include vaccination, infection prevention control, and workforce summaries. In terms of stress testing the plans, we had our first event with NHS England for executive members across the ICS at the ICB this Tuesday, and there's currently ICS exercises with operational teams and ICS partners across this week and next week, and then a regional stress testing event happening later this month. Locally, we're also going to do some localised exercise stress testings with key teams hosted by our emergency planning officer on the back of some of the regional, on the back of some of the ICS-led exercises that are ongoing this week. There are, as always, some risks to our plans, and they're included within the documents, but I just want to draw out two really. One is admission avoidance and our high levels of emergency admissions that we've seen increase over the last few years, and the system's ability to meet the admission avoidance plans that have been put in place that are aiming to kick in across Q3, and also the main risk in our ability to reduce our bed occupancy, and that our local and system-wide schemes are going to impact on reducing that bed capacity, because if they do, we've modelled a reduced level of escalation beds across this winter. And Chair, I just want the board to note the risks to that delivery, and seeking the board assurance, board sign off of the assurance statement for sign off in submission. Thank you.
Thank you, Andy. an awful lot of work goes into this, and we do our very best to plan for all eventualities. And in advance of winter, I want to, in anticipation, thank all clinical and operational colleagues for their hard work and tenacity that obviously happens 24 hours a day, and for our executive colleagues for their leadership. Unlike some businesses, the work goes on all of the time, and therefore we ask our colleagues to be available on call, and that very often translates into being working out of hours in order to keep our services safe. So thank you for that. Any questions, comments for Andy? No. So in that case, we are asked to approve the Herefordshire Wye Valley Winter Plan for 2025 and to approve the board assurance statement for onward submission to NHS England. If any board colleague is not happy to approve that, will you please raise a digital hand? No hands raised, so therefore we can sign that off with board approval. Thank you very much, Andy. Okay, the next section is items for noting and information. So some committee summary reports, starting with the foundation group minutes and from an action log from the meeting on the 6th of August. Is anybody any particular comments or happy just to receive that? Okay, thank you. And then 2 lots of quality committee report and minutes from, because of the timing, we had 2 in June, so the 6th of June and the 26th of June. Ian, anything you'd like to pick out for the board?
No, Chair, nothing to add, but happy to pick up any issues that colleagues wish to raise.
Thank you. Any questions for Ian? No. Thank you very much. And that brings us then to perinatal services quality report. I think this is you, Lucy, please.
Yes, thank you, Chair. I'm going to take the report largely as read, as there are no specific escalations for board oversight today. I just wanted to update, since the board last met, our new leadership team have joined us. So Justine Jeffrey, who sent her apologies for the board meeting today, has joined as our new Director of Midwifery, and that's a shared director's post across Worcester Acute Maternity Services, where Justine has been the Director of Midwifery for some time, and she's going to share her experience and leadership over at Wye Valley. And then our Deputy Director of Midwifery has also commenced in post, and that's Susan Hughes. Also, since we last met nationally, they have appointed Baroness Amos to lead the independent investigation into maternity and neonatal services. And the national team are just going through the process of selecting those trusts that will be part of that investigatory process. And they're likely to announce the trusts in the forthcoming days. What you'll see in Appendix 3 of the report is just a high-level overview of our local response to the national ask following the announcement of the independent investigation into services. I'm not going to go through each of those, but I would just want to highlight in relation to that cultural piece about how we behave and how we work together better. We were already ahead of the game. We'd held a series of multidisciplinary team summits earlier in the year throughout March and April, where the teams developed their charter of how we work better together and how we create a culture of a really positive set of values and behaviours amongst our staff who care for our service users. And they developed a charter of part of that, and we have an ongoing piece of work to progress that further. And then really, although I said I hadn't got an escalation, I just want to, you'll see reference in there, importance of the Maternity Neonatal Voices Partnership. And we work really closely with the MNVP. They're independent of our services, they provide due scrutiny, but they also provide really, really valuable feedback to us around service user experience. And we are just a little bit worried about the sustainability of that model moving forward. And we have escalated that to colleagues in the region and nationally. It's a particular concern for us in Herefordshire because actually some of our MNVP leads have left their posts, and due to restrictions on recruitment within integrated care boards, we're not able to recruit to those posts currently. We have escalated that, and there will be a discussion at the local maternity neonatal system board next week to discuss and see how we progress with that, because they are a really important and valued part of our arrangements. Other than that, I'm happy to take any questions and take the report as read. Thank you.
Thank you very much, Lucy. Any questions or comments for Lucy? Thank you for raising the issue about the MNVP recruitment, and I know through the work that we've done as executive and non-executive safety champions that's something that Sharon has also flagged with regional colleagues. We've talked earlier about wanting feedback from our patients and service users. That is a very structured approach in maternity and neonatal services that we value enormously, so losing that would be very detrimental to us. That really comprehensive user voice shaping our services is invaluable, so do please keep us updated on progress with that and escalate if there is anything that the board needs to do more formally. Thank you. Okay, and the next one's with you as well, Lucy, the patient experience quarterly report.
Thank you, Chair. I'm going to be really brief. I've already touched on the patient engagement elements and family and friends feedback earlier in the meeting. The report and more information related to this report was discussed in detail and given due scrutiny at Quality Committee last week. So I just wanted to give a couple of what am I worried about and what are we doing about it. So we do continue to see a high number of complaints into our services, and when we benchmark the numbers that we receive across our foundation group and even nationally, we are an outlier in that regard. Similarly, the number of patient comebacks, and by comeback what we mean is individuals who come back to say they're not satisfied with our initial response to their complaint. Again, the numbers are high and we don't benchmark well when we compare ourselves to other colleagues. And you'll also note in the report that the top themes in relation to complaints tend to be around communication, attitude, behaviours and values. Now, we're not an outlier, that is a national picture, you would see that across many trusts, but we're concerned about it, and we're particularly concerned around those complaints around the attitude, values and behaviours of those teams caring for our patients. So what are we doing about those things that I'm worried about? We are doing a deep dive into the attitude, values and behaviours piece, and we're going to bring that to Quality Committee for due scrutiny in due course. And then we need to rapidly, the Public Health Service Ombudsman guidance around complaint handling was published probably over a year ago now. We were unable to look at the true implementation of that last year due to resource constraints and gaps in the team that were unexpected. But we need to rapidly introduce that sort of best practice guidance into our handling of complaints, because that is all about early conversations, early resolution and dealing with things as they happen rather than them becoming a formal complaint. So if we implement the PHSO guidance, understand the values, attitudes and behaviours piece, then I think those things that concern me currently should improve moving forward. Happy to take any questions.
Thank you, Lucy. Any questions, comments or reflections for Lucy? No, and it is something that we talked about at length at Quality Committee, and I know something that non-executive colleagues rightly show significant interest in and scrutiny. So we do everything and encourage you to do everything we can to improve that, and some of the work that Jeffrey and others have been leading around leading empowering organisations and our communication style, what you said and how you said it and what people hear and how they perceived it aren't always in line. So everything we can do to make people's experience, and if we get things wrong, we will always say thank you for telling us, and we're sorry that it didn't go as you wanted to, and sometimes there are things that we need to learn to ensure that we get it better next time. But that early conversation with patients and service users, I think, is invaluable to understand how people would like us to respond. And we very definitely do not support a defensive culture. We will always want to learn and be open and therefore grateful when people take their time to raise concerns with us. Equally, as we heard, an awful lot of our patients and service users are immensely pleased with the care that we give them, and that's because the vast majority of our staff do such a fantastic job day in, day out, and we're very grateful for them and all that they do. Okay, that brings us to the end of the papers and the formal business for today. Are there any other items of business that we need to be considering today? No, and I don't believe, Gwenny, that we've had any questions from members of the public. No, we haven't. So that almost gets us to the end, and Jane cannot turn her camera off or decide to leave before I take chair's privilege of saying a few things to recognise the absolutely phenomenal contribution that Jane has made to the NHS. I've had the privilege of working with lots of people, and over the years going to award ceremonies where people get their certificate that says, I've worked for the NHS for 20 years, or I've worked for 25 years, or worked for 35 years, or worked for 40 years. And it's about 3 weeks or so before Jane will have worked for the NHS for 45 years. So by any count, that is the most incredible contribution, and we are indebted, Jane, to you for your unwavering commitment to the very best patient care that we can provide. It started training as so born not in Herefordshire and Worcestershire, but only just over the border into Shropshire. But Jane has been a local resident for most of her life, and very much committed to this part of the world. Ventured to the John Radcliffe in Oxford to train as a nurse. Seemed like a good idea, was in the family, and progressed through a variety of clinical roles. But unsurprising to those of us who have worked with Jane, leadership sort of took over. Jane does quite like to have an idea and make it happen. So the idea that she would be in a backward role and not making things happen was never going to be true. So a lot of years working in Worcestershire, then with our colleagues in South Warwickshire Foundation Trust as Director of Nursing and Chief Operating Officer. And for the last 10 years been working with us, and the last 9 years as our Managing Director, where Jane's professional growth expanded into system leadership, and I think, having been an exceptional clinical and acute hospital leader and community services, obviously in Warwickshire, embraced the opportunity to work with partners in general practice, in the local authority and in wider services, and therefore her leadership not only of Wye Valley but of the One Herefordshire has been phenomenal. Jane doesn't give up, so tenacious, committed, enthusiastic. You know, here's a hurdle, well, that's all right, that didn't quite work, so I'll find another way around it. And for those of us who bear I was going to say armchair support for her recreational activities, it is phenomenal. So the energy that Jane brings to work, she takes in spades on holiday. So there is not a challenge that either she has or one of her daughters throws at her that she doesn't say, yep, I'll give it a go. So retirement doesn't really feel like a word that is appropriate. I think the next chapter, who knows what it's going to bring, but we know, Jane, that you will throw your all into all that life has ahead for you. We are indebted for your leadership. We will miss you hugely. We have a great team, and we know that we, under Stephen and Sarah's leadership, the team will continue to do. But your legacy, we were talking this morning, learning by doing. You know, let's do it. Here's an idea. Let's try it. Let's make things happen. So we wish you well. We, as I say, we'll say all of this again in slightly different ways at various times over the next month, but I didn't want today's meeting to go without formally giving our thanks and our love, and thank you for all that you do.
Thank you.
Oh, very few words. Wonderful.
I said them at the beginning.
Yeah, you did.
You did. Fantastic team, and it makes it very easy to lead. But yeah, I'll have lots more opportunity in the next 3 weeks to say that individually and collectively, and to, as you say, our partners and everybody else. But thank you very much for those really kind words.
Good, thank you. The date of our next public board meeting is the 2nd of October, when we meet again at 1 o'clock, and our annual general meeting, as Jane mentioned earlier, is, I can't remember the date, somebody will tell me, is it the 26th of September? It'll be on our website. Apologies. Lucy, do you know?
25th, it's my wedding anniversary, which is why I know.
Congratulations, and what nicer way of celebrating than to have our annual general meeting. But thank you everybody, and thank you to members of staff, colleagues, members of the public who've taken the time to join us today, and please keep well and don't forget to get your flu jab when offered. For board colleagues, we have some items of a confidential nature, so can I suggest we take a few minutes and reconvene at 15:15 into the private section. Thank you.